Right. Okay. So I hope you have been studying and revising what we have discussed already, upper limb and lower limb. We will start with abdomen today. There will be two classes on abdomen. It's quite a big topic. So we will split into two classes. And at the end of the second class, we will discuss the questions. Right? So let's start. And as usual, at any point, if you have any doubt, you can ask me to stop. If you want any slide to be shown again, you can ask for that. Right? Okay. So we start with the various parts of the abdomen, the regions, the 9 regions of abdomen. So if you divide the abdomen by two mid-clavicular lines vertically and two horizontal lines, the transpyloric plane and the intertubercular plane, you get 9 regions. Okay. So transpyloric plane is at the level of the pylorus. We will come to that. And if you trace the iliac crest on each side, the highest point on the iliac crest is the iliac tubercle. So a plane joining the iliac tubercles is known as the intertubercular plane. So two vertical lines, the two midclavicular lines, and the transpyloric plane and the intertubercular plane gives you 9 regions. Okay. So transpyloric plane is at L1 level. It is midway between the suprasternal notch and the umbilicus. Sorry, and the symphysis pubis. Okay. And the intertubercular plane connects the tubercles of the iliac crest of the two pelvic bones at the L5 level. Okay. This is L5, this is L1, and the two mid-clavicular lines gives you 9 regions. What are the 9 regions? The right hypochondrium, epigastrium, left hypochondrium, the right lumbar umbilical region, the left lumbar region, the right groin or the right iliac fossa, then the hypogastrium and the left iliac fossa. Okay, these are the 9 regions. Now, a very common confusion is if someone asks you how many quadrants are there of the abdomen, do not say 9 quadrants. Quadrants means four. Okay, so in that case, if it is abdomen, the two costal margins, the abdominal lateral margin, and the inguinal ligament. This is the abdomen, the umbilicus. So if they ask you the quadrants, so there are 4 quadrants: right upper, left upper, right lower, left lower. But 9 regions of abdomen, 4 quadrants of abdomen. Is this clear? Why do we need to know about these 9 regions? Because clinically, in our surgical practice, a very common presentation, one of the most common presentations is pain abdomen. Okay. So patient will point to a region of the abdomen and say, I'm having pain over here. So you have to know what are the structures lying in these 9 regions so that you can correlate clinically what may be the source of the pain. Say, for example, very common patient coming with right lower abdominal pain. One of the most common differentials will be acute appendicitis. Apart from that, you have to know what other structures are present here. That also age-wise and gender-wise. Okay. So young male with RIF pain, think of acute appendicitis. Young female, you also have to think ovarian torsion, ovarian hemorrhagic cyst, ectopic pregnancy, all these things. Similarly, patient coming with right hypochondrium pain, you will think of acute cholecystitis. Patient with epigastric pain, you think of a gastritis or a pancreatitis. Okay, so that is why it is important clinically. We continue with the layers of the abdominal wall. Okay, so there are 4 main layers: outside inwards. We have the skin, we have the superficial fascia. Now, this fascia has again two components: a superficial fatty layer, the Camper's fascia, and the deep membranous layer of the Scarpa's fascia. Then you have the muscles with their fascia. There are three flat muscles, the external oblique, internal oblique, and the transversus abdominis with the fascia transversalis. And you have two vertical muscles, the rectus abdominis and the pyramidalis. And then you have the parietal peritoneum. So you look at this diagram. So outside inwards you have first the skin, then this Camper's and Scarpa's fascia. Then you have the muscles, external oblique, internal oblique, transversus, and the transversalis fascia. Then you have the extraperitoneal fascia, this one, or the preperitoneal fat. So there's a thin layer of fat between the fascia transversalis and the peritoneum. Okay, and then you have the parietal peritoneum. You enter the parietal peritoneum, you enter the abdominal cavity, the peritoneal cavity. Then this is again very important. So the concept of arcuate line. Okay, so arcuate line, this arcuate line. Okay, look at this diagram. This is the person seen from the front. So arcuate line is an imaginary line midway between the umbilicus and the symphysis pubis. Okay, the umbilicus is somewhere around here. Symphysis pubis somewhere around here. So between these two, midway is the arcuate line. Why is it important? Because the arrangement of the layers of the abdominal wall differ above and below the arcuate line. This is important from a practical surgical point of view. Here you see the rectus abdominis muscle, the two rectus. Same here also, there are two rectus. The above diagram, this one is how the layers are arranged above the arcuate line. This one is how they are arranged below the arcuate line. So follow this carefully. Above the arcuate line, here you have the external oblique muscle, this one, which then becomes the aponeurosis. Okay, so the external oblique aponeurosis continues in front of the rectus abdominis muscle and fuses in the midline in linea alba with that of the opposite side. So from two sides, the external oblique aponeurosis comes in front of the rectus and fuse in the midline. Below the arcuate line, same thing happens. External oblique aponeurosis from each side come and fuse in the midline and linea alba. So far, so good. Next layer, internal oblique aponeurosis. So above the arcuate line, the internal oblique muscle is coming. It is splitting into two. The aponeurosis is then splitting into two. Okay. One layer comes in front of the rectus, comes to midline, to linea alba, joins with the other side. Another layer goes behind the rectus, continues behind the rectus, comes to midline, joins the other side. Okay. This is above the arcuate line. Below arcuate line, there is only one layer of the aponeurosis which goes in front of the rectus. There is nothing behind the rectus. Comes to midline, joins the linea alba with the opposite side. Deeper inside, you have the transversus abdominis muscle. Okay. Above the arcuate line, muscle comes, aponeurosis forms. Above the arcuate line, this aponeurosis is behind the rectus muscle, coming to midline, joining with linea alba in the midline. Below arcuate line, even this one goes in front of the rectus to opposite to the midline with the linea alba. Okay. And then you have the fascia transversalis and the parietal peritoneum. So what you need to remember is below the arcuate line, there is no posterior rectus sheath. There is only the fascia transversalis and the parietal peritoneum. Whereas above the arcuate line, the posterior lamina of the internal oblique aponeurosis and the fascia transversalis form the posterior rectus sheath. Is this clear to everyone? Which part of the entire thing? Okay. So I'll summarize what I said. Arcuate line, imaginary line midway between the umbilicus and the symphysis pubis. The layers of the abdominal wall, they differ in their arrangement above and below the arcuate line. Above the arcuate line, external oblique aponeurosis comes in front of rectus. Internal oblique splits into two. Anterior lamina goes in front. Posterior lamina goes in behind rectus. And the transversus aponeurosis, the transversus abdominis, this goes behind the rectus, above the arcuate line. Below arcuate line, external oblique, internal oblique, transversus, all of them come in front of the rectus muscle. There is nothing behind the rectus muscle. There is no fascia aponeurosis behind the rectus muscle. Okay. So the rectus sheath is formed by these aponeurosis. So anterior rectus sheath is formed by the external oblique aponeurosis and the anterior lamina of the internal oblique aponeurosis. And posterior is formed by the posterior lamina and the transversus aponeurosis. Whereas below arcuate line, there is no posterior rectus sheath. There is only anterior rectus sheath formed by fusion of all the three aponeuroses. This is clear now? Anyone else? Any doubts? Okay. Posterior abdominal wall, it is not very important, just for completion sake. So you have the some important muscles like the iliacus, then the psoas major, the psoas minor, quadratus lumborum, and then you have the fascia. The psoas fascia lying in front of the psoas major, right here, and you have the thoracolumbar fascia, which has three layers: the anterior layer, middle layer, and the posterior layer, with some muscles encased between the three layers. Okay. Now, again, a very important topic, the inguinal canal. Okay, please pay attention. Please listen very carefully. Very, very important concept. So, this is a canal, a potential space in the groin region, this part of your body. Okay, it is a pathway for structures to pass from the abdomen to the external genitalia, particularly important in males. Okay, now, whenever there's a space, it is a potential weakness in the abdominal wall and therefore a common set of herniation. So, what is a hernia? Hernia is basically when a content of a cavity tries to come out of the cavity through a weak spot. Okay, so abdomen is a closed space with many structures inside, intestine, omen, everything is there. There are a few potential weak spots through which the contents of the abdomen may protrude outwards, leading to what is known as a hernia. Common sites being the umbilicus and the inguinal region. They are the common sites for herniation because these are potential weak spots. So any condition, say old age, say smoking, which causes the muscles to get weaker, or any condition leading to increased intra-abdominal pressure, straining repeatedly during passing stool, chronic constipation, okay, then someone with a long-standing cough, coughing for a long time, then those who lift heavy weights, be it in the gym, be it because of their profession. So any condition which leads to an increased intra-abdominal pressure or conditions which have led to weakening of the abdominal wall muscles can lead to development of a hernia through these potential weak sites. Okay. So for now, we will focus on the inguinal hernia and the inguinal canal. So it is a canal, it's a pathway for structures to pass from inside the abdomen to the external genitalia. It's usually about 4 centimeters long and it is the site of herniation. So why is it important? As I said in males, as you know, the testicles, they develop inside the abdomen, and during embryonic development, they slowly descend from inside the abdomen to the scrotum. There has to be a pathway. So they develop inside the abdomen. Then, with every passing month in the development period, third week, the third month, fourth month, fifth month, sixth month. Okay. So they gradually descend from their site of origin within the abdomen. At some point, they come at the opening on the inguinal canal, then they pass through the canal, then they come out of the deep ring, and then finally they reach the scrotum just before delivery. Okay. So during a development, the testes, they develop in the abdomen, descend through the inguinal canal. Structure called the gubernaculum. It is attached to the inferior part of the testis, which kind of guides the testis to the scrotum. Okay, so there are hormones which push the testis from inside the abdomen outwards, and the gubernaculum is somewhere around here. With time, this contracts, this shrinks, becomes shorter, and the testis is therefore pulled from here to the scrotum. And this canal is a pathway for the testis to come from inside the abdomen to the scrotum. And while the testis is coming, it is flanked by a outpocketing of the peritoneum, known as the processus vaginalis, and the abdominal wall muscles. So look at this. The testis has developed inside the abdomen. Okay, inside the abdomen. Now it is coming through the this canal into the scrotum. This is the future scrotum. This is the abdomen. So while this is coming, this gubernaculum, this green fibrous band, this is guiding the testis to come to the scrotum. While this is coming, so it drags a fold of the peritoneum. This thing is coming along with it. This is known as the processus vaginalis. And obviously, if something is coming out of the abdomen, it will be flanked by the abdominal wall muscles and the fascia. So external oblique, internal oblique, transversalis muscle, all these things come along with this, and they subsequently form the scrotal wall. Okay, so layers of the scrotum, we will come to this later on. They are formed by the same muscles which form the wall of the abdomen. All right, and gradually, once that the testis reaches its spot, the gubernaculum becomes a small ligament, and this processus vaginalis, this obliterates. All right. Any questions so far? Okay. Just continuing with the inguinal canal. So you imagine the canal to be a box, or rectangular cuboidal box. Okay. This is the roof. This is the anterior wall. This one is the posterior wall. This is the floor. This is the lateral side. This is the medial side. This is side where you have the symphysis pubis somewhere over here. This is the outside. And you have two openings, the two rings. One is the deep ring. This is on the posterior wall. This is the posterior wall, deep ring. So this posterior wall is actually the side towards the abdomen, abdominal cavity. And this is towards the skin outside, anterior wall. Okay, so between the skin and the abdominal cavity, between the layers of the abdominal wall, there is this space which is the inguinal canal. Okay, so deep ring is the opening, internal opening. Okay, this is created by the fascia transversalis. This is the internal opening. So there has to be two openings. Something has to pass from inside the abdomen to the canal and then out of the canal. So there has to be two openings. One opening from the abdominal wall and from the abdominal cavity, another opening from the canal outwards. So structures have to pass from the abdomen through the deep ring into the canal. Then they pass through the canal and they come out of the canal to the scrotum through the superficial ring. Okay. So deep ring is the internal opening. It is formed by the fascia transversalis. And then you have the superficial ring right here. This is the external end of the canal, lies just superior to the symphysis pubis, and this is formed by a gap in the external oblique aponeurosis. Okay. So you look at this diagram over here. These are the inferior epigastric vessels, these vessels. Okay. This is the rectus muscle. This is the inguinal ligament. So Hasselback's triangle is a space between the rectus muscle medially, the inferior epigastric vessels laterally, and the inguinal ligament inferiorly. Okay. This is a space which is just medial to the inferior epigastric vessels, and just lateral to the inferior epigastric vessels you have the deep inguinal ring. Okay. So structures will pass from inside the abdomen through the deep ring, enter the canal, pass through the canal, and come out of the canal to enter the scrotum through the superficial ring. Is this clear? Yes or no? Yeah, okay. So you just imagine something has to pass from inside the abdomen to the scrotum. Okay. So there has to be a corridor, a passage with two doors. One door from inside the abdomen into the corridor. Another door from the corridor outside, means in the scrotum. Okay. So the door between the abdomen and the passageway is the deep ring. Okay, which is formed by the fascia transversalis. That is the deepest layer of the abdominal wall, as we have learned earlier. So innermost layer, fascia transversalis, because just after that is the peritoneum. So the fascia transversalis, there's a defect in that, which forms the deep ring, which is the passageway for the structures to pass from the abdominal cavity into the inguinal canal. Now the structures have entered the canal. Now they have to pass through the canal and pass out to the scrotum. So one more door is needed. That is the superficial ring, which is formed by the outermost layer of the abdominal wall, which is the external oblique. So through a defect in the external oblique, those structures pass from the canal into the scrotum. So what is the pathway? The testis and vas, everything. So they have to pass from the abdomen to the deep ring, through the canal, out of the superficial ring to the scrotum. That is the pathway. Okay. Deep ring is formed by the innermost layer of the abdominal wall, obviously by common sense logic, which is the fascia transversalis. Superficial ring has to be formed by the outermost layer, which is the external oblique. Okay. And that is the understand the concept. And this diagram shows something about the anatomy. The deep ring lies lateral to the inferior epigastric vessels. This is an important point you must remember. The deep ring lying lateral to the inferior epigastric vessels, and the Hasselback's triangle. Why is it important? We will read later on. Hasselback's triangle lies medial to the inferior epigastric vessels, and its boundary is the rectus abdominis muscle, the inferior epigastric vessels, and the inguinal ligament. Okay. Is this clear now? Everyone?
Link, sir. Laterally or medially?
Sorry.
Deep ring. So epigastric
Yes.
vessels are laterally, so medially.
Can you please type? I can't hear you. If someone had a question, inferior epigastric vessels, they run medial to the deep ring. The deep ring lies lateral to the epigastric vessels. As you can see in this diagram, these are the epigastric vessels, right? These are the vessels. Medial to it is the Hasselbalch's triangle. Lateral is the deep ring. All right. Yeah. Okay. So inguinal canal, the boundaries. A simple mnemonic is MALT. M-A-L-T. How so? So roof, anterior wall, floor, and posterior wall. MALT. Two muscles, two aponeurosis, two ligaments, and two T's. So roof is formed by the internal oblique muscle, transversus abdominis muscle. Okay. Anterior wall, external and internal oblique aponeurosis. Floor by two ligaments, inguinal ligament and lacunar ligament. This is on the medial most part. This is the lacunar ligament. And posterior wall by the fascia transversalis and the conjoint tendon. Okay, two T's. And the inguinal canal. So what does it contain? It contains the spermatic cord in males, down ligament in females, the ilioinguinal nerve, and the genital branch of the genitofemoral nerve. Okay. Boundaries, two muscles, two aponeurosis, two ligaments, and two T's, and the inguinal canal contents. Next. Now understand the concept of a direct and an indirect inguinal hernia. So any hernia in this groin region, which are coming from the deep ring or to the posterior wall, are inguinal hernias. It is known as an indirect inguinal hernia when the herniation occurs through the deep inguinal ring. It is a direct hernia if it is through the posterior wall of the inguinal canal, the so-called Hasselbalch's triangle. Okay. So you see this diagram again. So any hernia through this deep ring is known as a indirect hernia. Any herniation from this area medial to the inferior epigastric arteries, the vessels, they are known as direct hernias. Okay. And the indirect hernia, the sac bulges into the canal via the deep ring lying lateral to the epigastric vessels. Direct hernia lies medial to the epigastric vessels. Okay, this is the most important difference between the direct and the indirect hernia. Direct hernia through the posterior wall, weak posterior wall, usually in adults, elderly due to weak muscles, and the sac lying medial to the epigastric vessels. Indirect hernia through the deep ring, lateral to the epigastric vessels. Okay. If you see this diagram of indirect hernia, this is the lateral side, this is the medial side. This is the, you will have the scrotum somewhere over here. This is the inferior epigastric vessel. This is the deep ring. The herniation has occurred through the deep ring. The contents have come through the deep ring. This part is the canal to the scrotum. So, defect, herniation through the deep ring, lateral to the inferior epigastric artery, it is an indirect hernia. Similarly, over here you see same diagram. This is the A medial side, scrotum is here. So epigastric artery is here. Herniation has occurred from here, which is medial to the epigastric artery through the posterior wall. This is a direct hernia. Okay. Had the herniation come from here, it would have been an indirect hernia. Since it is medial to the epigastric artery, it is a direct hernia. Clear, everyone? Right. Then the spermatic cord. So, spermatic cord contains all the three layers of the anterior wall. Okay. The three layers are the external spermatic fascia, cremasteric muscle and fascia, and the internal spermatic fascia. So they come from the external spermatic fascia is derived from the external oblique aponeurosis. Cremasteric muscle and fascia from the internal oblique muscle. Internal spermatic fascia from the fascia transversalis. So what happens is this is the abdominal wall like this. The testis is here. Then the testis will come downwards like this, and finally here like this. So the covering, this covering is same as these layers. So, but since they are not in the abdomen anymore, the names have changed. So the external spermatic fascia is same as the external oblique aponeurosis. The internal, the cremasteric muscle and fascia is same as the internal oblique aponeurosis. And the internal spermatic fascia is same as the fascia transversalis. Okay. And what does the spermatic cord contain? It contains the blood vessels, testicular artery, cremasteric artery, artery to the vas, and the pampiniform plexus of testicular veins. And nerves, it has the genital branch of the genitofemoral nerve and various autonomic nerves, and the vas deferens, lymphatics, and the, if it is persistent, the processus vaginalis. All right. Similarly, and another important question commonly asked, layers of scrotum. So the concept is same, just like this. So since this is being dragged down from the external abdominal, from the abdominal wall, so layers of the scrotum are same as that of the abdominal wall, except the names have changed. So what are the names now? So the skin remains same, the skin subcutaneous tissue remains same. Then you have the one extra layer is the dartos. Dartos is a subcutaneous muscle present only in the scrotum. Then it's same. External spermatic fascia, cremaster, internal spermatic fascia, then the tunica vaginalis, then you have the testis. So layers of scrotum, remember, important question. Is this clear? Yes or no? Okay. So now we will continue with the structures inside the abdomen, starting with the blood vessels. So the abdominal aorta. Ilioinguinal nerve is, some books say it's a content. Actually, it is not in the sense that it does not enter through the inguinal, the deep ring. It kind of pierces through the posterior abdominal wall. So in surgical books, you will find they are not mentioned as a content. Okay. It is there in the canal, but not a content per se, because they don't have the same route from deep ring to superficial ring, not like that. They just pierce into the canal from the posterior wall. All right. Okay. So the aorta, which is branches, the abdominal aorta, um, the aorta starts from the heart, obviously, as you all know. So the thoracic aorta becomes the abdominal aorta after it pierces through the diaphragm at the T12 level. We will discuss the diaphragmatic openings later on. For now, just remember the abdominal aorta starts from T12 level. Okay. At that level itself, it gives off the celiac trunk. Celiac trunk has three branches: left gastric artery, the splenic artery, and the common hepatic artery. Okay. Then further down, it gives the superior mesenteric artery at L1 level and the inferior mesenteric artery at the L3 level. Okay. These are the unpaired branches of the abdominal aorta. Three unpaired branches: celiac trunk, SMA, and IMA at T12, L1, L3 level. There are several, and one more, the median sacral artery. This is another last unpaired branch. The rest are all paired branches. Starting from above downwards, you have the inferior phrenic arteries, you have the adrenal arteries, you have the renal arteries at L1, L2 level, you have the gonadal arteries, L2 level, then the 4 or 5 lumbar arteries, and then the common iliac arteries. So the abdominal aorta will bifurcate into the common iliac artery at L4 level. Okay. A simple way to remember is bifurcation at L4 level. So bifurcates at L4 level. Okay. Bifurcation at L4 level. Okay. You cannot miss out these points. Very simple point, very important points. Starting off the abdominal aorta, T12, celiac trunk T12, SMA L1, IMA L3, bifurcation L4, renal arteries L1, L2, testicular arteries L2. We must not forget these. Then the common iliac, it gives off two branches: external iliac, which gives a few branches and then continues as the femoral artery in the limb, and the internal iliac artery. This supplies all the pelvic organs. It gives off the vesical arteries, the superior gluteal, inferior gluteal, internal pudendal, uterine, middle rectal, all the branches to supply all the pelvic organs. Okay. In the venous drainage. Now, there are several systems of venous drainage in the abdomen. One is the systemic venous drainage, one is the portal venous drainage, one is the axial system of venous drainage. Okay, we will see all of them individually. Which slide? This one? Yes. Do you have a question? All right. So, venous drainage, as I was saying, there are three systems: the systemic the portal, and the azygous system. Systemic venous drainage starts at L5 level, where the left and right common iliac veins they join to form the inferior vena cava. Okay, this is the IVC, and IVC receives many tributaries along the way. The testicular, the ovarian veins, the renal veins. Okay. Now, one important point you must remember on the left side. See, on the right side, the IVC directly receives the testicular vein, the renal vein, the adrenal vein, all these things. They all drain separate into the IVC. On the left side, the adrenal vein and the gonadal vein, both of them drain into the renal vein. And this then drains into the IVC. So this is a different way of drainage as compared to the left side. On the as compared to the right side. On the right side, the adrenal, renal, and the gonadal they drain individually into the IVC. On the left side, adrenal, renal, gonadal they together drain into the IVC. Remember this point. Then the azygous system. So azygous means unpaired. Azygous means unpaired. Okay. So the azygous vein, it starts from the right subcostal and the right ascending lumbar vein. These two veins, they form the azygous vein. Azygous vein continues upwards through the diaphragm in the thorax, drains into the SVC. Okay. Then you have the hemiazygous vein. Forms in the same way. The left subcostal and the left ascending lumbar vein, they form the hemiazygous vein, which joins the azygous vein. Similarly, you have the accessory hemiazygous vein, which forms here. It also drains into the azygous vein. Okay. Then the lymphatic drainage. So it starts with some lymphatic trunks. The intestinal trunk, the lumbar trunks, they form a sac, lymphatic sac at L1, L2 level, known as the cisterna chyli. Okay. This one, the cisterna chyli, continues as a thoracic duct. Okay. After passing through the diaphragm at the T12 vertebral level. Okay. There's the opening in the diaphragm at T12 level through which the thoracic duct ascends in the thorax. It continues upwards, running between the aorta and the azygous vein. At the T5 level, it crosses to the left side and continues upwards. Then at this C7 level, it joins the left subclavian vein at the same point where the left IJV enters the subclavian vein. Okay. So thoracic duct starts from cisterna chyli through the diaphragm at T12 level, upwards, T5 level goes to the left side, process then joins the left subclavian at the same point where it joins the left IJV at the C7 level. Okay. And then the portal venous system. So a portal vein is one which carries blood from one organ to the other, to another organ, not into the circulation system per se. So the hepatic portal system, what happens here? Most of the blood from the abdominal organs goes into the hepatic portal vein. Okay. So spleen, the entire intestine, all the blood is received via the mesenteric veins, the splenic vein, and that blood goes into the portal vein, which takes blood to the liver. So after processing the blood in the liver, it is delivered to IVC via the hepatic veins. Okay. So the portal vein takes blood from the organs to another organ, that is the liver. After the liver filters that blood, then it goes into the IVC via the hepatic veins. So how is the portal system formed? The superior mesenteric vein and the splenic vein, they join to form the hepatic portal vein. Then in the liver, the blood is filtered. Then through the right and left hepatic veins, it goes into the IVC. So what are the main tributaries of the portal system? The splenic vein and the SMV. The IMV joins the splenic vein. Okay, so IMV is a tributary of the splenic vein. So once the IMV joins the splenic vein, then the splenic vein and the SMV, they together form the hepatic portal vein. Is this clear? With me, everyone? Right. Now, as I was saying, the diaphragm, so it is a musculo-tendinous sheet. It has two main functions. One is it separates the thorax from the abdomen. And secondly, it is a very strong muscular organ. It contracts and relaxes, resulting in alteration of the volume of the thoracic cavity and the lungs, and therefore helps in inspiration and expiration. Okay. In diaphragmatic paralysis, the person will not be able to breathe. So diaphragm is like a dome-like structure. It is arranged. It's a sheet. So it has to have some peripheral attachments all around the body circumference. Peripherally, at the back, it is attached to the vertebra via arcuate ligaments. In the sides, attached to the ribs. Okay, ribs surrounding. So the diaphragm is attached to each and every rib, the seventh to tenth, and then the 11th, 12th ribs. And in the front, with the xiphoid process of sternum. So sternum in the front, ribs at the side, vertebra at the back. These are the peripheral attachment of the diaphragm. In the center, there is a central tendon where all the muscle fibers they fuse, and the tendon itself is attached to the inferior surface of the fibrous pericardium. Okay, so it's not a free-lying membrane in the body. It's attached in the center and in the sides. Nerve supply C3, C4, C5. Do not forget this. And another view of the diaphragm. So this is the front. This is the sternum. These are the vertebra at the back, the ribs at the sides. So here you have the attachment via the arcuate ligaments at the ribs and the sides, sternum in the front, and this pale region is central tendon attached to the pericardium over here. Now, there are three openings as you can see. One is this, one is this, and there is this. Okay, three openings. Three openings at three different vertebral level. Okay, so as you can see in this sagittal section, the diaphragm is not a flat structure. It is a curve like this. Therefore, the three openings come at three different levels. At the highest level, at T8 level, is this opening, this one, the vena cava hiatus. Then at little below level, it is the T10 level, it is the esophageal hiatus. And further below, at T12 is the aortic hiatus. Okay, A, B, C, three openings at T8, T10, T12 level. And through these three openings, various important structures pass. You must remember what passes through which opening at which level. So T8, how to remember? Vena cava. 8 letters, T8. T10, esophageal hiatus. One, two, three, four, five, six, 7, 8, 9, 10. 10 letters, T10, esophagus. 8 letters, vena cava, T8. And aortic hiatus. 6, 6, 12 letters, T12. Okay, that's how you remember the names in the levels. What passes through which opening? Look at this table. So, vena cava opening at T8 level, you have obviously the vena cava with the right sphenic nerve. Esophageal hiatus at T10 level, obviously you have the esophagus. Esophagus will come with its own branches, the vagus, which is its own nerve, the vagus nerve, and its branch of artery. Esophageal branch of left gastric artery. Okay. And the aortic hiatus at T12 level, obviously you have the aorta along with the thoracic duct and azygos vein. Okay. Vena cava hiatus T8, vena cava with right phrenic nerve. Esophageal hiatus T10, esophagus with its vagus nerve and its own artery. Aortic hiatus T12 with aorta, thoracic duct, and azygos vein. Okay. Which previous slide do you want? This one. Any questions, anyone? Is it okay so far? Okay. The person who asked for the previous slide, is this the one you're asking for? Okay. So shall we continue? Okay. So now let us start with the organs, the GI tract to start with. So GI tract starts from the esophagus till the anal canal. Okay. It is divided into three regions: foregut, midgut, and hindgut. Okay. Why this division? Because see, for any organ to develop and to survive, it needs blood supply. So it is not possible for one artery to supply the entire GI tract from top to bottom. So developmental wise, during the process of embryonic development only, the body has decided one part to be supplied by this artery, another part by this artery, another part by another artery. So that's how we have divided for our ease of understanding and also for clinical applications. Foregut starts from the esophagus, the stomach, and ends at proximal duodenum. We will see the parts of duodenum. Just remember, till the major duodenal papilla in second part. That's the end of foregut, along with the pancreas, liver, and the gallbladder with the bile ducts. So that is all the foregut derivatives. Esophagus, stomach, duodenum till second part, major papilla with pancreas, liver and gallbladder supplied by celiac trunk and its branches. Okay. Midgut starts from where the foregut ends, from the major duodenal papilla from second part, then third part, fourth part, jejunum, ileum, cecum appendix, ascending colon, the proximal two-third of transverse colon. That's the end of midgut, supplied by superior mesenteric artery and its branches. Hindgut from the distal one-third of transverse colon to descending colon, sigmoid colon, rectum, and anal canal till the dentate line. That is the end of the hindgut, supplied by IMA and its branches. Okay. So esophagus, it is a fibromuscular tube, length about 25 centimeters, starts from C6, inferior border of required cartilage, C6, descends downwards. First, if you remember thorax, superior mediastinum, then the posterior mediastinum, enters the abdomen via the esophageal hiatus at T10 level. The layers of esophagus, inside outwards, mucosa, submucosa, muscularis, inner circular, outer longitudinal, and adventitia. This is one part of the GI tract where there is no serosa, adventitia. And there are two sphincters. One is the upper esophageal sphincter. Second is the lower esophageal sphincter. The upper sphincter is actually a sphincter, a muscle by the cricopharyngeus muscle. It's actually a sphincter is there. Now the lower esophageal sphincter, there is no anatomical sphincter structure per se, but there are various factors whose effect results in a sphincter-like effect. I'll tell you what I mean. The esophagus enters the stomach. So had it been a straight tube like this into stomach, and if it is something like this, so you can make out the difference. A sphincter but the acute angulation acts like a sphincter, as if something is there to stop the reflux from happening. Secondly, in the abdomen, there is a positive pressure which keeps the esophagus compressed. Okay. So this is the thoracic esophagus. This, all right. Sorry about that. Yeah. So the last factor leading to a sphincter-like effect is that the diaphragm passes through the esophagus passes through the right crus of diaphragm, which also has a Pinchcock-like effect. So you understand that there are various factors which prevent the gastroesophageal reflux from happening, okay, resulting in a sphincter-like action, but there is no actual sphincter there per se. All right. Do you understand this? Yes. Okay. Now, one point to remember is the esophagus has various constrictions due to various structures which pass around it, in front of it, behind it. So first constriction is the cricopharyngeal sphincter at 15 centimeters from the incisor. So how is this measured? When you're doing an endoscopy, the endoscope has markings, measurements, and the measurements are done from the upper central incisor. So when the endoscopist is doing the procedure, he can see how much of the tube has gone inside from the markings on the tube, and the measurements are taken from the upper central incisor. So the first constriction is seen at the at 50 centimeters, which is the cricopharyngeal sphincter. Second is by the aortic arch at 22 centimeters. Third one at the left main bronchus at 27 centimeters. And finally, when the esophagus opens into the stomach at 38-40 centimeters. Okay. And the esophagus is flanked by right and left vagus nerve, one on each side. And to understand the arterial supply, venous drainage, and the lymphatic supply drainage, we divide esophagus into three parts: upper third, middle third, and lower third. So, upper third, blood supply, inferior thyroid artery, inferior thyroid vein, and the lymphatic drain into the deep cervical lymph node. Middle third, esophageal branches of the aorta, and blood goes back into the venous and the azygous system. And the lymph nodes drain into the mediastinal lymph nodes. And the lower third artery, the branches of the left gastric artery, the venous drainage into the portal system, and the lymph nodes, the lymphatic drain into the left gastric and the celiac lymph nodes. Okay. Shall I proceed? Okay. Next, the stomach. So, as you know, the parts of stomach where the esophagus enters, it's a cardia. Okay. Then the fundus, body, and the pylorus. So, this pylorus gives name to the transpyloric plane. This is at the level of L1. Okay. Toughest layer is submucosa. Okay. Throughout the GI tract, anywhere the strongest layer is submucosa. So whenever you are doing any kind of surgical anastomosis in your suture or in your staple, you must include the submucosa. I didn't get this last sentence. All right. Now the blood supply of stomach, very, very important topic. So you start with the abdominal aorta, then celiac trunk at the T12 level. Celiac trunk gives three branches: common hepatic, splenic, left gastric. The common hepatic gives off the gastroduodenal artery right here and continues as the proper hepatic artery, which then supplies the gallbladder as the cystic artery and goes to the right and left hepatic artery in the liver. Then this gastroduodenal artery, it gives the the proper hepatic also gives off the right gastric artery from here. Then the GDA, the gastroduodenal artery, it gives the right gastroepiploic artery. Then the splenic artery gives rise to the short gastric and the left gastroepiploic artery. Okay. So the stomach is supplied by left gastric, right gastric, right gastroepiploic, left gastroepiploic, and the short gastric arteries. You must remember where each of these arteries come from. Left gastric is a branch of the celiac trunk itself. Right gastric comes from the proper hepatic artery. Right gastroepiploic comes from the GDA. Left gastroepiploic comes from the splenic artery. Short gastric comes from the splenic artery. Okay. You cannot forget or miss out anything from this topic, blood supply of stomach. Very, very, very important. Is this clear to everyone? Keep drawing and practicing. That's all I can say. This diagram you must keep drawing. That's the only way to remember this. There's no mnemonic that I know of. You can search online, but it's very important. Okay. Now continuing, after stomach comes the small intestine, duodenum, jejunum, and the ileum. Okay. So duodenum, parts of duodenum, there are four parts of the duodenum. Superior duodenum, this blue part known as D1, the descending part D2. So D2 has a papilla, a major duodenal papilla. What happens here, I'll tell you later. Just remember for now, there is a major duodenal papilla where the common bile duct and the pancreatic duct, they open. Okay. This is the pancreas. Okay. This is the pancreas. The common bile duct will be, the gallbladder will be somewhere. So the liver is somewhere here. Okay. Gallbladder is here, receiving the right hepatic duct, left hepatic duct, cystic duct. CBD is coming here. Pancreatic duct will come here posteriorly. So the CBD and the pancreatic duct, they join and open in the major duodenal papilla. So this is where the foregut ends. The rest of the second part of duodenum is from the midgut. Okay. So proximal to this foregut supplied by celiac artery, distal to it midgut by the SMA. And then this part is D3. Behind this third part lies the IVC and the aorta. And then the D4, the ascending part, fourth part of duodenum, where there is the duodenojejunal junction or the DJ flexure. Is this clear to everyone? If you don't ask questions, I'll assume it is clear. Next, the two parts, jejunum and ileum. They are the distal two parts of the small intestine. Okay, they are intraperitoneal structures. The jejunum starts at the DJ flexure, and the ileum ends at the ileocecal junction with the ileocecal valve. Grossly, there are a few macroscopic differences which you can see during surgery. Jejunum is basically in the left upper quadrant, ileum lower right quadrant. The jejunal walls are thicker as compared to ileum. The vasa recta are longer with less arcades and more reddish in color. The ileum has shorter vasa recta with more arcades and pinkish in color. Not very important from a clinical person point of view, but may be asked in your exam. Now, the appendix. So, appendix starts from the posterior medial aspect of the cecum, and the free end, the tip, is highly variable in its location. Okay, so the most common is retrocecal. This is the most common location, followed by pelvic. Okay, other parts are subcecal, preileal, postileal. So it is ileum. So if it lies in front of ileum, it is preileal. If it is behind the ileum, it is postileal. The most common location is retrocecal location. Okay, an appendix, as you understand, it is from the midgut. Therefore, supply will be some branch of the SMA. So appendicular artery is a branch of the ileocholic artery, which is a branch of the SMA. Okay, and McBurney's point, you must be remembering. So umbilicus and the right anterior superior iliac spine. You draw a line, a junction of lateral 1/3, medial 2/3 is known as the McBurney's point. It is classically described as the point of maximum tenderness in acute appendicitis. Okay, but clinically it is not always the case. Okay, but it usually is. Don't recall what is there clinically. For your exam point of view, remember acute appendicitis, point of maximum tenderness, the McBurney's point, a junction of medial 2/3, lateral 1/3 of a line joining the umbilicus to the right anterior superior iliac spine. Regarding the pain of acute appendicitis, there is a typical pattern and there is a logic behind that pain. Okay. So initially, the pain is felt at the umbilical region. Why is that? When the inflammation is just starting, it is only the visceral peritoneum that is inflamed. Okay. Pain from visceral peritoneum is not very well localized by the individual. The afferent fibers, they are from the T10 segment of spinal cord, and the T10 dermatome on the body is in this region, in the region of umbilicus. Okay, this is the area supplied by the T10 dermatome. So whenever the inflammation is just starting, the visceral peritoneum is inflamed, the pain is received by the T10 fibers from spinal cord, and therefore the pain is at the area of umbilicus. Gradually, when the inflammation progresses, it increases, then the even the parietal peritoneum gets inflamed. All right. So when the parietal peritoneum is inflamed, the pain from that is very well localized, which is at the region of the right iliac fossa in the McBurney's point. So the patient will describe that the pain had started in the umbilicus. Gradually, after some time, maybe after a few hours, it has gone to the right lower abdomen. That is a very classical description of a pain of acute appendicitis because of how the pain is perceived by the body. Initially, poorly localized pain felt in the umbilical region. When the parietal peritoneum is inflamed, well localized pain in the right iliac fossa. Okay, is this clear? Is this topic clear? Appendicitis. Yes or no, guys? Please respond. Right. So previous slide, someone asked. Yes. Okay. Now continuing. During the embryological development of the fetus, so it starts with something like this. There's the yolk sac, the amniotic cavity, allantois. Then the yolk sac kind of invaginates outside and is connected to the primitive gut by this omphallomesenteric duct. With it gradually progresses, becomes a more tubular structure like this duct. This part is connected to the umbilicus, abdominal wall, and this is the gut. And the omphallomesenteric duct is a communication between the umbilicus and the gut. This is during fetal development. Normally, ideally, this duct should get obliterated completely, it should disappear with no remnant. However, in certain conditions, this duct does not disappear either completely or partly, leading to various clinical conditions. So, if the duct remains completely patent between the umbilicus and the gut, so it is a fistula, White-line fistula, a completely patent structure. There will be discharge of fecal matter through the umbilicus. It may so happen that the duct may get completely fibrosed, but it is still there, it has not disappeared, leading to a cord-like structure. It may so happen a part of the duct may remain patent, whereas the proximal and the distal part have got fibrosed, leading to a cyst formation. It may so happen that the distal part has completely disappeared, but there is an outpouching from the gut, leading to a diverticulum formation, which is known as the Meckel's diverticulum. Or it may so happen that the distal part has fibrosed, but is persisting as a cord. It is not. It is no longer patent, but it is there as a cord, and a part of it is as diverticulum. So it is a diverticulum with a cord. Okay. And the very classical 2% rule of Meckel's diverticulum. You have it is present in 2% of the population. It is quite rare, not very common. It is 2 times more common in males. It is present 2 feet proximal to the ileocecal valve. It's about 2 inches in length. And the mucosa, although it is a continuation of the small intestine, but the mucosa is often different from that of the small intestine. It may be a gastric mucosa or pancreatic mucosa. Okay. Is this clear? Michaels? Right. So in the same way, this one you saw when this vitelo-intestinal duct is persistent. So in the same way, if this allantoic duct remains persistent, so here the omphallomesenteric duct or the vitelline duct, it communicates with the gut. The allantois communicates with the cloaca or the future urinary bladder. Okay. Therefore, in the same way, if you have a persistent allantoic duct between the umbilicus and the bladder, completely patent, you have a patent urachus. So there will be urine dribbling through the umbilicus. You may have a part which is obliterated from here, but a part which is present here. So it's a sinus. Some mucus discharge may happen from the umbilicus, not urine, because this part is no longer patent, but there's something is patent here with some mucosa here, which will produce some secretions, which is a umbilical urachal sinus. Then in the same way like the White-line duct, 2 sides have got obliterated, but there is a persistent cyst. There will be urachal cyst. And opposite of what we saw in the last slide, if there is a persistent diverticulum from the bladder, rest of it is obliterated. So it will be a vesico means bladder, vesico-ureteral diverticulum. Okay. Clear so far? Very simple. Now continuing with the gut. So the large intestine or the colon, the parts you all know, it starts from the IC junction. Then the first part is the starts with the cecum. Appendix arises from the cecum, ascending colon, transverse colon, descending colon, sigmoid colon. This is the hepatic flexure. This is the splenic flexure. This is the rectosigmoid junction, rectum, anus. And midgut ends at proximal 2/3 of the transverse colon. Till here. So right from the second part of duodenum, jejunum, ileum, and all this cecum, ascending colon, till here is the midgut supplied by the superior mesenteric artery and its branches. From here is the hindgut. The distal one, the transverse colon, descending till the rectum is the hindgut. Large intestinal colon, grossly there are three features which helps you to identify them during surgery. First, there are three muscular bands all over the colon, starting right from the cecum till the sigmoid. You have the tinea coli. You see this band, the three bands on three sides. This helps you identify the colon. During surgery, if you have to find the appendix, what you do is you find the colon, you trace the tinea. Where the three tinea end, that is where the appendix will arise. That is the importance of tinea. Similarly, on the other side, where the tinea ends, the sigmoid ends. After that, you have the rectum. So one is the tinea coli. Three muscular bands. Then you have some appendices epiploicae, few fat-like outportions of fat, and some hostrations or circulations. Okay. And in a cross section, you will see the tinea coli, these three muscular bands, circulations like this, and appendices epiploicae. Blood supply. So aorta, SMA, IMA, division at midgut and hindgut. So SMA branches are the ileocolic artery, which gives the appendicular artery, then the right colic artery and the middle colic artery. IMA, left colic artery, sigmoidal branches, and the superior rectal artery. Okay. Following everyone? Yes or no? Yes. Now there's something called the marginal artery of Drummond. So this is a communication between the SMA and the IMA. Okay. Why is it important? This artery is usually of not much role. Okay. But sometimes it may so happen that the blood supply to the SMA or the IMA is compromised because of some reason. Maybe because of some atherosclerotic plaques or some embolus which is blocking the supply of the SMA or the IMA. Now understand, each of these SMA, IMA, they supply such important structures, such vast areas of the gut. So any occlusion of SMA and IMA can have devastating effects, and they do occur. So when the SMA gets occluded, the artery of Drummond in that scenario opens up, becomes functional, and blood is diverted from the IMA to the SMA to kind of help supply the SMA territory. All right. Similarly, if the IMA gets occluded, then blood from the SMA may be diverted to some extent to supply the IMA territory. But here's a catch. The arterial occlusion can happen either suddenly or gradually. Suddenly, say the patient has a atrial fibrillation. So a thrombus may form in the left atrium. That thrombus may give rise to a embolus, which may occlude the SMA or the IMA. SMA is more common. So that's a sudden occlusion. Suddenly the artery is blocked. Another scenario may be, say, long-standing smoker, long-standing diabetic, obese patient, high cholesterol levels. So atherosclerotic plaques are gradually depositing over many years until at some point the lumen becomes so narrow that the blood supply is occluded. Not sufficient blood is received by the gut for its survival. So in these two scenarios, when there's a sudden occlusion, the artery of Drummond cannot suddenly open up and start supplying. But when there's a gradual occlusion over many days, in this scenario, these collateral circulations they open up and they continue to help the gut survive till a certain level. Beyond that, it will also give up. So, artery of Drummond, the importance is that it is a collateral circulation which helps in the gut circulation when the SMA or the IMA gets occluded. Did you understand? Okay. Then the rectum. It is the most distal part of the large intestine. Now, how is it distinct from the colon? As I said, there's three features of the colon: Tinea coli, Hostra, and the Diploides. They are absent in the rectum. The rectum is again divided into three parts. The superior third, it is covered by the peritoneum on the front and the two sides, anteriorly and laterally. Middle third, only anteriorly. Lower third, there is no peritoneal cover, it is below the peritoneum. So lower third of rectum is extraperitoneal. It is not in the peritoneal cavity. All right. So you have to visualize, you have to imagine a three-dimensional structure. A tube is coming. Posteriorly, there is no peritoneum. Okay, this is some fascia. So the tube, the upper part, it is covered with this peritoneal on the front and the two sides. The front part is continuing in the middle third also, no longer on the sides. Lower third, there is no covering. Peritoneum has ended above only. Did you understand? And the peritoneal fold gives rise to pouches. In males, this is in male, you have the rectum over here, you have the bladder over here, and the peritoneum is coming like this. So you have the rectovesical pouch in the male. Recto, rectum, vesicle means bladder, rectovesical pouch in the males. In females, you have the rectum, you have the uterus. So you have the rectouterine pouch of Douglas in females. Okay. Blood supply of rectum, arterial supply, superior rectal artery, which is a continuation of the IMA. Then the middle rectal artery, which is a direct branch of the internal iliac artery, and the inferior rectal artery, which is a branch of the internal pudendal artery, which in turn is a branch of the internal iliac artery. Okay. And venous drainage, superior rectal vein, which goes into the inferior mesenteric vein, which, if you remember, goes into the splenic vein, which goes into the portal vein. So the superior rectal vein, the blood drains into the portal venous system via the IMV. The blood drains into the internal iliac veins, which goes into the IVC, which is the systemic circulation. So this is the area of portocaval anastomosis. Okay. I'll repeat this part. Superior rectal vein goes into the inferior mesenteric vein. Internal iliac veins. This is the systemic circulation. So the portal and caval, vena cava, systemic. So portal and caval veins, they form a network in this region, forming a portocaval anastomosis. Okay. There are a few important areas of portocaval anastomosis in our body. One is the rectum, one is in the lower end of esophagus. These two you must remember. Okay. Next, coming to the rectum and anal canal, how this thing ends, how the GI tract ends. So we start with the sigmoid colon over here. This is sigmoid colon. This is the rectum. And you have the rectosigmoid junction. Then the anal canal is here. We have the anorectal junction. Okay. This is the rectum. This is the anal canal. Now the anal canal is divided into two parts by the dentate line. Proximal to dentate line, it is basically a continuation of the rectum. Therefore, a part of the hindgut. Distal to the dentate line, it is no longer a part of the gut. It is from the proctodium. So there are various structural and anatomical differences in the anal canal above and below the dentate line. Okay. What are the differences? So the dentate line divided in two parts, upper and lower part. Above the line, it is from the hindgut. Below is from the proctodium. The differences. So above the dentate line or the pectinate line, the epithelium is same as rectum, columnar epithelium. Blood supply, same as rectum, superior rectal artery. Venous drainage, same as rectum, superior rectal vein. Lymphatics, same as rectum, internal iliac nodes. Okay. Below the dentate line, it is different. It is from the ectoderm. So there is non-keratinized stratified squamous epithelium, supply from the inferior rectal artery, venous drainage from the inferior rectal vein, lymphatics, the superficial inguinal nodes, nerve supply. So above the pectinate line, it is not sensitive to pain. It is only sensitive to stretch. So when the spot is stretched, you feel the urge to defecate. Whereas below the pectinate line, there is somatic innervation, which is sensitive to pain, temperature, touch, and pressure. Okay. Is this clear to everyone? Any questions so far? Any slide you want to be shown again? Okay. So in our next class, we will start from the liver. We will cover liver, pancreas, the biliary system, kidney, the various internal organs, and then we will discuss the questions. So please read up what we have discussed today. This is a large topic. Keep revising and reading. Okay. Anything you want to ask? All right. So, bye, guys.